Welcome, colleagues. When it comes to nail pathologies, our instinct is often to jump straight to pattern recognition. But what if we took a step back? In this explainer, we're going to reframe our entire approach. We're going to build our diagnostic skills from the ground up, linking every single clinical sign we see directly back to its anatomical origin.
So, here's our roadmap. We'll start by establishing the nail as a true diagnostic window, and then we'll quickly run through the anatomic blueprint. From there, we'll get into the good stuff, decoding signals from the matrix, then the nail bed, interpreting the language of color, and we'll wrap it all up with a classic differential diagnosis challenge.
All right, so first things first. The most crucial point here is to really see the nail not just as some appendage, but as a window. Every little change we see is a signal, and that signal can point to anything from minor local trauma all the way to a major systemic condition.
And this, right here, is the simple principle that honestly unlocks everything else. The location of the insult dictates the clinical sign. Period. Is the problem in the matrix, the engine room, or is it in the nail bed, the foundation? Answering that one question is always the most important first step you can take.
Okay, so with that in mind, let's quickly review the functional anatomy. And look, we're not just naming parts here. We're really focusing on how each structure's job directly creates the pathologies we see every day in the clinic.
So, the matrix. It's the engine, right? But notice the clear division of labor here. The proximal part, the bit further back, it creates the top layer of the nail plate. The distal matrix, which you can see as the lunula, creates the bottom layer. This distinction is absolutely fundamental. It's the reason why pitting originates from a proximal matrix issue, while something like true leukonychia comes from a problem in the distal matrix.
And if the matrix is the engine, well, the nail bed is the foundation. Its number one job is adhesion. It's basically the glue holding the nail plate down. So it just follows, logically, that any pathology here, whether it's psoriasis or onychomycosis, is going to manifest as a failure of that adhesion. In other words, onycholysis.
And finally, you've got the proximal nail fold, which basically acts as the matrix's bodyguard. Now, when this protector gets inflamed, paronychia, the problem can cascade. You get secondary damage to that underlying matrix, and that leads to plate abnormalities like Bow's lines.
So here it is. This is where it all comes together. A problem in the proximal matrix gives you surface changes, like pitting. A problem in the distal matrix gives you true leukonychia. And a problem in the nail bed leads to adhesion issues, like onycholysis. This little chart, this is our diagnostic key.
Okay, let's put this into practice. We'll start with our first set of clinical signs, focusing on signals that come directly from the nail matrix, the engine room of the whole nail unit.
Pitting. We've all seen it 1,000 times, right? It's one of the most common signs we encounter. So let's break it down using our anatomical framework.
So what's actually happening? This definition connects the sign directly back to a specific malfunction. You get these little foci of parakeratosis in the proximal matrix, and they get built right into that top dorsal layer of the nail plate. As the nail grows out, those defective cells shed, and they leave the pits behind. The anatomical origin is just that precise.
And this is where your clinical eye comes in, because the pattern of the pits helps you narrow the differential. You've got the large, deep, almost ice pick-looking pits of psoriasis. Contrast that with the very fine, superficial, almost geometric pits you see in alopecia areata. That difference is a classic clue, but you have to look closely.
Bow's lines are similar in that they act like a historical record. You get a temporary shutdown of that proximal matrix, and it creates this transverse groove. The width of the line tells you about how long the insult lasted. And here's the really cool part. By measuring its distance from the proximal nail fold, you can actually date the event, knowing that fingernails grow roughly 3 millimeters a month. It's like a little timeline on your patient's finger.
Okay, now let's shift our focus distally. We're moving from the matrix down to the nail bed. And when we talk about the nail bed, the primary themes are adhesion and, of course, what's happening right underneath the nail plate.
All right, onycholysis. Here we're seeing another fundamental failure, this time in the nail unit's adhesion system. And the key clinical pearl here, the thing to always remember? This is a nail bed problem, not a nail plate problem.
The anatomy is pretty straightforward. A problem with the nail bed or the hyponychium leads to this separation. The space that's created fills up with air and debris, and that's what gives it that classic white or yellowish look. The nail plate itself is often totally normal.
Now, the tricky thing is, the list of potential causes is huge. which is why you have to look for other signs. Do you see an erythematous border? That points you towards psoriasis. Is there a lot of subungual hyperkeratosis? You should be thinking onychomycosis. And of course, we always have to consider drugs, trauma, and even systemic diseases like hyperthyroidism.
Splinter hemorrhages are a direct sign of a vascular event in the nail bed. The capillaries there are arranged longitudinally, and that's what dictates their linear shape. Now, while most of them are distal and just from simple trauma, here's the crucial point. If you see proximal splinters, that should absolutely raise your suspicion for systemic disease, things like endocarditis or vasculitis. That's a huge clue.
All right, let's talk about color. This is one of the most critical diagnostic categories we deal with because distinguishing between different types of discoloration is essential. The implications can range from completely benign to, as we all know, life-threatening.
So here is a fantastic diagnostic maneuver. Just apply a little bit of pressure. This simple test differentiates true leukonychia, which is a matrix problem within the plate, from apparent leukonychia, which is a nail bed issue like edema that just makes the nail look white. If it blanches when you press on it, the pathology's in the bed, not the plate. It's a simple, elegant test based entirely on our framework.
Now for melanonychia, having a systematic approach is absolutely vital. You see multiple bands, that often points to benign causes like medications or just racial variation. But a new, single-banded adult, that's a red flag. From there, we apply the ABCDEF rule to stratify our risk. Any concerning feature, a wide band, a changing appearance, pigment extending onto the fold, or a high-risk digit like the thumb, means we have to seriously consider a matrix biopsy, which is and remains our gold standard.
Okay, to finish up, let's apply our anatomical framework and our tools to a really challenging and common diagnostic dilemma that I know we all encounter in the clinic.
This is the question, right? This is the one we all face. The history isn't clear, and you have to make the call. Is this just trauma, or is it something more sinister? Let's see how our framework, and a little help from dermoscopy, can help us tell the difference.
Once you put the dermatoscope on it, the clues really start to become clearer. A hematoma is typically homogeneous in color, with a nice, sharp proximal border. And crucially, it migrates distally as the nail grows out. Melanoma, on the other hand, often shows non-homogeneous color, it's got blurred borders, and it tends to widen over time, especially proximally. You see, by consistently starting with anatomy, we can bring this level of clarity to all of our nail cases. The nail isn't just showing you a problem, it's telling you a story. Our job is just to learn its language.